But welcome all the SMS traveling fellows. And you guys are old enough to remember that Tom Cruise movie Minority Report?
Yeah.
Okay. All right, good. So this is more of a fellow level talk. It's really just to talk to our incoming fellows about what the basics of a TLIF are. So it may not be like super, high level for our visiting SMS faculty, but we're going to talk about the pros and cons of the different approaches, some case examples, and then probably most importantly for the fellows, the actual like step-by-step components of the procedure, which I got from AO. So this slide, everybody's seen it. A lot of different ways to get to the lumbar spine, obviously. The ones that we are probably most fluent in are the lateral and the TLIF. And obviously we've got really good access surgeons here. So where I trained with Rick Fessler, it was like MIS TLIF is king. So it's kind of like the exact opposite of what you fellows are seeing here, where we do mostly laterals. We did very few laterals. He believed very strongly, not just in MIS, but like that MIS was definitively like meant tubular retractors, and that there's like some physics behind the way a tubular retractor retracts tissue and how the tissue can refill that space. And so that's sort of what I, cut my teeth on in Chicago. And then when I came here, I was like, oh yeah, like MIS TLIF is great. And everybody was like, no, it's the worst. So, I felt sort of like an outcast, as you can see here. But there are advantages and disadvantages to both. And certainly I'll concede that there are a lot of advantages to a lateral or oblique approach. And indeed, I probably do more laterals than TLIFs now that have been here for a couple of years. But you get a larger graft. It can still be done to MIS. You definitely get a better indirect decompression via lateral. I know that that's something that folks that do these TLIFs endoscopically talk about, but I'm not entirely convinced. Obviously, you can do multi-levels really quick in the lateral retroperitoneal corridor, and you don't have to do much of posterior muscle dissection. You can just do perc screws. But as you know, the plexus can be in play depending on the level. Bowel injury, if you really get confused, sympathetic chain, it can be hard to get 4-5 for those of us that aren't Bobby Slack. You generally can't get to 5-1. And then if you try to do the oblique approach, there's a pretty significant learning curve. ALIF, I think there's a ton of advantages. You have to have a good access surgeon, which I would say here, like that's not a foregone conclusion. So where I did my residency, I don't know if it's different now, Stephen, but like when we used to do ALIFs at Columbia, it's just like, it was like the liver transplant surgeon one day, and there's like some other vascular surgeon the other day, and we bring let's get it, a liter of blood, and so like and it wasn't much better at Rush. I mean, I think there was a really good guy, and then he retired, and we just like stopped doing ALIFs for a year because we just couldn't count on the access. So I think in private practice, a lot of times there's like a couple guys that are just really slick, and they get slick at it because it's a good practice environment for them. But in a lot of academic situations, I don't think you can really count on it. But if you can get there, and we can, you can get great lordosis, obviously, with the ALL release, large footprint. You can really dial in a physiologic restoration of the lordosis at L4 to S1, which is where most people are going to need it. And then again, you can do MIS in the back. But big exposure, somewhat, more morbid, and also a lot more risk in terms of vascular injury, retrograde ejaculation with young men. Ileus, no matter how slick your exposure person is, can be an issue. Two positions, access surgeon, excessive lordosis. I know Ollie and I had a case like that recently. Well, I don't even know if it's lordosis, but sometimes you can certainly put the SAP into the frame and somebody that's really collapsed if you totally reconstruct them. And mostly limited to L4 to S1, although our guys can get to L3-4, which again, like at Columbia, was like nobody even think about that. So, like the things that I would get like the first couple of years in conference, like one of the fellows presented a TLIF, it'd be like almost like I like did something really bad. Like, oh my God, how could you? Like, you'll never get any sagittal plane correction. You won't get any reduction. You won't be able to get a decent graft in. It'll take you forever. You'll probably get a CSF leak and a palsy. It'll subside, and most of them won't for you. So, like, what are you? Like, what kind of surgeon do you think you are? But there are some advantages. And in reality, I don't know. Like, didn't they always quote you like 20% of surgeons do laterals? And I'm sure, like, I don't think that that's accurate anymore. I think it's like for our generation, it's probably more like 50 or 60.
No, I think it's still.
Yeah, I think
Right,
that's
it's
a work for it.
50%.
Has that been your experience? Most people do are traveling estimates, faculty?
Like in our own departments?
Yeah, just like where you train, where you practice now. Do most of your partners do lateral surgery, or is it TLIF much more prevalent?
50% of I'm in Jefferson, 50% of the neurospine surgeons do laterals. But in my residency at Vanderbilt, there's 0 laterals. So I think that averages out to about 25%.
Yeah. All right, so maybe it is still 20%.
Yeah.
But regardless, a huge portion of the surgeon community is really relying upon it, and it does have certain advantages. So obviously, you're putting a tube down there, you're directly decompressing the nerves, you're seeing them. You don't have to rely on indirect decompression. You can do it MIS, dude. Some folks will do it through an 18 millimeter tube. I think that's like typing with your toes. I mean, you can do it, but like doesn't mean it's a good idea. But you can definitely do it, I think, through a 22 millimeter tube. That's one position. You can certainly try to maximize the lower doses through positioning. It's very familiar coming from the back. You don't need an access surgeon or anybody like that. You're not going to have any bizarre visceral complications, but it's a small corridor. And so you can't get in a great cage most of the time. The lordosis question, certainly you're not going to get as much lordosis as you would via an ALF. There's not a great, I think it's assumed oftentimes you'll get better lordosis via a lateral approach. There's not a lot of data that supports that. And I've looked at my, my limited series, but it's pretty equivocal if you really try to get lordosis with a TLIF and an expandable cage and compress in the back. So I don't know that there's a huge delta in terms of lordosis between lateral and TLIF unless you're doing like an ALL release. But you do have the potential for duotomy, certainly. You could cause neuropraxia through retraction. And then cage subsidence continues to be an issue, particularly if you have an expandable cage. And I'll talk about that a little bit. So if you guys did see Minority Report, there's the basic concept is like there's 3 psychics that sleep in this like water pool, and then they try to predict future crimes like a TLIF. And 2 of them, like whenever there's like they don't all agree. Like they basically predict the future, and the Minority Report is the one psychic that disagrees. But sometimes the Minority Report is actually happens to be the right in certain instances, even if it's the Minority Report.
Not today. Okay.
But not today. Okay, so my early experience, some pros, some cons. So this is, like in my hands now, maybe I would do a lateral here, but early on, I was way more comfortable with TLIF. So 4-5 spondy, bad lateral recess stenosis. And especially being in this conference, I was like, oh man, I really got to get lordosis. Like these guys, something's going to work, blah, blah, blah. And so they have all these like expandable cages. So you can see there, get a graft in there, and you can like really crank these things up. So I was like, oh my God, I got like 23 degrees of segmental lordosis from 10. I'm a man. And like I should put it on one of those emails you get, from NuVasive, where it's like I did like a 1-level ACDF, like I'm awesome. But 3 months later, you can see it's like massive subsidence, and I think that was a real learning point for me. You can't just like put these solid, rigid, rectangular, titanium like expansive grafts and then just crank it up and expect the bone to hold it. So this lady had like 4 or 5 months of back pain until it just kind of healed. And you can say she basically went back to 10 degrees. In terms of data for this, there's certainly good evidence that there's more subsidence with expandable cages. And if you're going to use an expandable cage that's rigid like that, then you really have to do bilateral facetectomies to release the segment. Because if you have one facet that's still spondylotic and is going to, constrain the segment, you could crank up a graft, it's going to subside. It's like over 5 times as likely. And obviously that takes a lot of time to do 2 MIS facetectomies if you're working for yourself. And that is just basically the data. You can see that the incidence goes from 5 to like 20 in the expandable group without bilateral facetectomy. So, at a place like Scripps where we've got really good vascular surgeons and all of our like mentor/colleagues are really good at lateral, you can sort of find yourself on a bit of an island. But there are certain instances where you will see patients that have had maybe a different type of surgery and some of the complications associated with that. So this is a patient I saw pretty early on from an outside surgeon and had an ALIF, and I don't know what the plate is for, but like other than that, like looks like a pretty good construct. It has this little spike that goes into the foramen, and I saw one of these recently together as well. So like, there are other complications associated with anterior access surgery. This is one I've seen a fair number of times. It's often a little bit difficult to predict because if the 5-1 disc space is totally collapsed, you won't see that like spondylotic spike. But then when you put in the graft, it'll raise it with the 5 vertebra, and then still have foraminal stenosis and radiculopathy, and so you can correct it, but it's another operation, obviously, to go in and drill off the set. So no approach is perfect. So this is a 64-year-old woman with L4-5 spondy, really bad stenosis. So this is, I think, in my hands, like a really good indication for a TLIF, because she's got terrible compression, so she needs a direct decompression. The psoas anatomy is not favorable. And I think she had some reason not to have an ALIF, but this is like a classic example of the monkey ear, like, or not monkey ear.
It's gonna look like a monkey.
The Mickey Mouse, the Mickey Mouse ear. They where you've got the floating psoas and the plexus kind of in jeopardy. Yeah. So I know there are a number of techniques where you can try to affect this via where you dock, et cetera, from a lateral corridor. But in my hands, it's just not worth it. So, but in this particular patient, she had pretty bad bone quality. So the subsidence issue is obviously an important one. And so with that in mind, we tried to do bilateral vasectomies, and I think we put in bilateral cages in this. Yeah, so this is Ryan Holt. So he was a very good fellow. So we basically just dropped down 2 tubes. If you've got somebody that you can work with, a co-surgeon or something like that, then you can actually do this with a little bit of pace. And the only thing to put in 2 grafts, the only thing I would say is the trajectory is very different because you're converging. So you have to take a pretty orthogonal trajectory. You can't go 45 degrees. You have to kind of both come very straight on. Otherwise, you'll make contact with each other, which we learned the hard way. I couldn't get this grafting because I was hitting his. So we had to kind of take him out and reposition him. But if you are able to do it, then you can get a pretty big footprint in there, kind of working simultaneously. And this is a graft I like because it has what's called adaptive geometry, just meaning when it expands, it's not rigid. And so it sort of conforms to the end plate. It's a lot less likely to subside. And this is just another image of that. So, and then this is another image of that without the K-wires. And then this is another friend of mine from TBI, Peter German, and he and I started doing this with 2 grafts, but it does take a lot of time, and not all fellows are comfortable doing their side by themselves, and so for the most part I've moved away from that. So another case of a TLIF and somebody who's got terrible bone, 83-year-old woman with breast cancer, meds, osteoporosis, but a really bad spondy and back pain, and is actually having some bladder functions issues. So when there's neurologic issues like that, we really obviously need to do a direct decompression, but we're worried about subsidence in somebody with osteoporosis and bone mets and all of that. Again, not a great psoas anatomy for a lateral approach. And you can get a sense there just how compromised your bone is, but also how much like calcium and spondylitic material is affecting her canal. So in this instance, obviously not somebody that's going to respond to indirect decompression, even if you can get a reduction. Like, you got to go in there and drill out that calcium, in my mind. So this is actually just one graft. So I got away from putting the 2 grafts. I think the graft that you choose, if you're going to use an expandable graft, is really important because they don't all sort of create the same amount of stress in the end plates. Without getting into any commercial names or anything like that, I'll try to just say what features I look for. And here's her final X-ray. I don't know why I showed it twice. Okay, so then reops. I think reops are another. TLIFs can often be a good procedure if you've got a recurrent disc herniation. Sometimes you can pluck the disc out from an anterior approach or a lateral approach, but oftentimes it's pretty difficult to do that. So you're going to have to do a direct decompression anyways. And in my mind, if you're doing a direct decompression, in most instances, then it's, you're already there. Probably it's easier to just place a graft from the posterior position while they're prone. The one caveat I would say, so this guy had disc herniation, obviously pretty significant there on the left. Took it out, did great for a couple of months. Then he had a really bad recurrence. And I think he did another discectomy. He did okay again. Then he had like a 3rd recurrence. So like a lot of you guys, I'll do, recurrent disc, I'll do a recurrent discectomy. And then the 3rd time that they herniate, that kind of shows that there's failure. When you're doing a TLIF for a 3rd time, MIS dilation, there's going to be a ton of scar, and the nerve roots are going to be pretty tethered and so forth. So I think it's important to have a TLIF graft with a pretty small insertion profile. I'm a big advocate for expandable cages. There's like 3 or 4 that I like, but I just think that if you try to get in there with a normal cage, there's going to be so much scar tethering the dura. You're not going to be able to establish Camden's triangle like you normally would in most instances. So it's better to have an expandable cage in the revision discectomy context, in my opinion. And this is this gentleman's postoperative film. So a couple considerations. I know that these pedicle-based retractors are a bit in vogue, or they were at least for a while, where you've got basically 2 retractor blades that are attached to the pedicles, and then you've got those medial blades, the lamina. I think it's kind of a hybrid approach. I mean, I think it's a lot more familiar to some surgeons, and certainly you've kind of got your pedicles as clear landmarks. But I don't think in terms of morbidity, it's the same. I tried one of these like once or twice, and then I got a postoperative CT scan for some reason, and I just remember looking like how much edema and stuff there was in the muscle. It looks like a shotgun went off in there. So it's really not the same as the tube, although I think it is a reasonable like half measure, certainly better than the midline takedowns we used to do when I was a resident. Like the approach we would take for a 1-level TLIF when I was a resident, like is horrifying in retrospect. But yeah, again, I think that using a tube is a far less morbid procedure. The one limit with the tube is sometimes it can be difficult to get across the disc space because it's a tube, and particularly if somebody's got like, you know, a fair amount of space, if they have a larger corpus. In San Diego, not too often a problem, but certainly in Chicago, we ran into it a lot. And so the longer your tube is, the harder it is. You're gonna have like less degrees of freedom. It's gonna be harder to get across and do good disc prep and all of those different things. So most vendors will make this little slit in a tube if you want them to, or you ask them to, and that gives you a lot more freedom, especially to work lateral to medial, because you can drop your hand. And as long as it's not too big of a slit, it'll actually not creep much. So all of the tubes I use have these little slits in them, and it actually helps a lot. So considerations regarding expandables. I do think expandables make a big difference in terms of lordosis. I think, you know, using bilateral fasciectomies can be important. I think that compression is important, but I do think expandables make a big difference. There's like 1,000 different variations of like rectangles that expand in the sagittal plane. I've got a couple issues with those. One is most of them will subside like gangbusters. The other is that their sagittal, like their lordosis, if you put it in like a bullet, you know, it's not going to be in the sagittal plane. It's going to be like 45 degrees off. So like that just kind of conceptually, I can't get my head around unless you've got some weird way to put it in completely sagittal. So that's an issue. This one on the upper right-hand corner, that's the Globus one. That's actually a pretty good cage. It's a little bit technically more difficult because you put it in like a banana and then you spin it and then you can expand it in that like ventral location. But if you do that and you can compress on it, it's really good. So technically a little bit more challenging, but certainly you can get really good results with that. A lot of experienced MIS TLIFers will use that cage or use that cage. To get around the subsidence piece, there's a bunch of different designs to try to increase the footprint. Most of them are pretty janky. When I was a fellow, that one in the middle we used to use a lot. And it actually, I think, works okay. Assuming nothing goes wrong, but it's not super easy to deploy as you might imagine. And most of them have some kind of design limitations. They're not super slick. This is one that I do like. It's actually predicated on like stent technology, where you're, you know, the way they open up stents, they'll put something in the side and it pops open the stent. And it's a similar concept where there's like a peak core, which is tie coated, and you put in a little metal shim and it pops it open. But there's some give in the expansion mechanism. So like it'll conform a little bit to the end plate, which is kind of cool. This is another one that I like, not so much because the expansion mechanism is that clever. I mean, it's just a gear like all the other rectangles, but it does have this little snaggle tooth on the end, which I think increases the surface area by like 20%. But it also, if you get it all the way ventral, that's like hook can be on stronger bone, and it just seems to subside less. But I think more than anything, it's from a manufacturer with our prior navigation technology allows you to do the entire procedure navigated, which is really nice because it's only like 4 X-rays. It's basically 2 X-rays, an AP and lateral plane, just to make sure that everything is where you want it. and then 2 x-rays at the end just to make sure that you've got like rods above and below. So it's like 4 x-rays as opposed to like 4,000. So the navigation is really nice. The other thing that's cool about being able to use navigation is a lot of us will use loops to do an MIS TLIF. And then you can like bring in the fluoro and stuff. It's really hard to both have a microscope and have fluoro coming in and out because like the microscope, the fluoro, it's a real pain in the neck. And so when I was in training, Dr. Fessler had these like this little camera that would go on my headlight, and then supposedly he could see what I was doing on like this little like grainy screen. But like halfway through, I realized like the camera was like it was like a you can't I hope it's not listening, but you can't see anything through the camera. Like you couldn't see anything. So he just kind of like that was his way. He had enough trust or whatever. But it's like a common like it was so grainy. Like you could like I think it wasn't even working once. Like, oh, it looked good. But like the battery was dead, you know? I'm like
It wouldn't kept irrigating itself.
yeah, right. Water coming out of the phone. But so if you are training MIS TLIF, it's really nice to do it under the microscope because then you can like be there with the fellow and you're like, okay, so now we've got this pro, you know, and so you can actually be there together. With navigation, you don't have to keep bringing the fluoro in for your different, you know, shavers, so forth. So it's really nice for teaching to be able to navigate it. Hopefully more navigation platforms will allow us to do that, but I think that that's something we'll see definitely happen the years to come. So when choosing a graft, I think you want to think about subsidence risk, you know, how does it expand? What's its footprint going to look like? Pseudo risk, you know, most of us have moved away from smooth peak, and bigger the footprint, the better. But most of that, I think, is disc prep. You know, there's guys that do MIS TLIFs in like 45 minutes. That I mean, all that really tells me is like they're not doing disc prep because it's impossible, I think, to do that with good fidelity and do it in less than an hour or less than 2 hours. But you can get good decompression if you're going direct decompression. If you're going to do a re-op through scar, just make sure you've got a small footprint because you won't be able to get a good graft in there without putting too much traction on the traversing or exiting nerve roots. And then I like to have a graft that I can place through a 22 millimeter tube just to kind of limit morbidity. And usually that means it has to be something that's MIS or something that's expandable. Okay, so steps. Again, this is more for the fellows. And these slides, I think Dr. O'Toole, who's also a Rush guy, put them together or showed them to me here. And they're from the AL. But this is a basic OR setup. There's a lot of different ways to skin a cat, but whatever's going to work for you. I wouldn't put the arms at the side like that, but you could come up with an OR setup that works. So what are the steps? So the first step for MIS TLIF obviously is figuring out where you're going to make your incisions. It's generally going to be 2 paramedian incisions, obviously one side for the screws, the other side for the screws and the TLIF. If you're doing it fluoro-based, 4 to 5 centimeters is a pretty good rule of thumb. The larger the patient, the more lateral you're going to have to be to kind of get a good trajectory in most instances. If you're using it with navigation, then it's a lot different because you basically get your spin. You put the PSIS pin in, then you do your spin, and then you can look on the screen and basically with the chicken foot determine like, okay, what's like the optimal trajectory to the laminar facet junction where I want to dock my tube? What's the optimal trajectory to the different screw insertion locations? And then you can kind of make a skin incision that accounts for all of that. So, okay, so you've planned it out, you've got nav or you don't, but regardless, you've got the tube down in the right place. And if that is true, then you should be looking at the laminar facet junction and basically see something that looks like this. So you get your soft tissue muscle plug out from inside of the tube, and then you're looking at basically the joint. And the first thing you should see, assuming we're at L4-5, would be the inferior articulating process of L4, as well as the lamina of L4. And so you need to remove that, obviously, to get into the TLIF corridor. And there's a number of different ways to do that. I think most MIS folks prefer to drill it. Certainly I do. And you can do this pretty quickly if you know where you are and you're familiar with the anatomy. And you basically just start with a laminotomy medially. And you take that up till you are basically just past the ligamentum flavum. That's usually a good sign that you're basically at the level of a pars. And you just take it laterally. The one learning point I would say is like the pars is actually quite a bit deeper than the lamina medially. So the first couple of times you can feel like, oh my God, I'm drilling, like what's going on? It's so deep. But if there's a listhesis, it's going to be deeper. And the pars is just deeper anatomically. And so you have to drill for a while to get that pars free. Some folks like to use a osteotome, which if like an expert, like Dr. Fester used to use an osteotome and it was super fast. And I think that that's a reasonable way to do it. You just have to be careful, obviously, because it's a sharp instrument kind of aiming towards the exiting nerve root. But the way you avoid injury to the exiting nerve root is you just have to basically do it under fluoroscopic guidance and just be flush with the pedicle. And if you're flush with the cranial pedicle, you should avoid the exiting nerve root. Likewise with the inferior pedicle. There's no question this is the fastest way to do it, but generally it doesn't take that long. And so I prefer to do it that way. Does that make sense? Like, Mike, like why you would do it that way? Because then you disconnect the lamina above and below. And you just have to just, yeah. Okay, so you've got the IAP off. Now, obviously, you want to get the SAP off. You can drill off a little bit of it, but the best way to do this is with a kerrison. And the reason is that you can basically just bite back towards the pedicle. So you can completely skeletonize that pedicle, which will give you the broadest corridor for your graft insertion. So once the IAP is off, usually I'll keep the flavum down. I'll try to establish the plane between the flavum and the SAP, and you can drill it or you can just bite back on it. But you want to be careful you don't drill into the pedicle. So then you've got your SAP off. Now you've sort of got your corridor. You can release the flavum at this point. Usually that's easiest done medially. And then you see your classic Camden's triangle with your thecal sac and your nerve root. Seeing the exiting nerve root, I don't necessarily think you have to see it. I generally like to, especially if there's a listhesis. Sometimes the nerve root is like right on top of the disc and sort of dragged on the disc. It's not like they're in the same depth plane because of the listhesis, where you might think that the nerve root is higher. And so, obviously you want to avoid any kind of praxia or injury to the nerve. And so I think finding it is generally a good idea. It shouldn't take that long. You just go up to the pedicle above and you should be able to track it out from there. And then you can protect it. And then this is sort of conceptually what you're seeing. As you can see, the natural trajectory leaves like 50% of the disc unaccounted for. And the more disc prep work you do, the better chance you're going to have of a good fusion. And so most of us will use these shavers, but most of the shavers will miss the ipsilateral, like ventral stuff. That's wrong. And the contralateral dorsal stuff. So it should be the opposite of what I write there. But basically those two areas where the red marks are easily kind of not accounted for. And so you want to potentially, if you have time or if you think it's appropriate, maybe change your tube angle a little bit, or at a minimum, change the angle of your shaver so you're trying to get that ipsilateral deep disc. And then for that contralateral superficial stuff, you can get like a downgoing curette and try to get some of that disc and scrape it down and then pull it up. If you spend like half an hour doing the disc prep or 25 minutes doing the disc prep, like I know there's some studies out there where like you only remove like 23% of the disc or something when you do a TLIF. That's like, if you're really paying attention and trying to do a good disc prep, like you can get most of the disc out. It just takes some time. What's that? 25%. Yeah. No, but you can. It's got to be thoughtful about it. Like, what am I not seeing? What's probably still there. Okay.
Are any of those instruments navigated too? Like you're right.
Only with one vendor.
Okay.
Yeah.
That's kind of nice too.
100%. 100%.
I would even say just even an open TLIF, right?
Yeah.
I mean, you're not sure how far across you are.
How deep you are. Yeah. It makes it. Yeah. So like, hopefully in the future, there'll be more and more navigation. Because I think TLIF is maybe like the best operation for it. You're putting all these instruments in dark, deep holes. And oftentimes you're not doing a great job of preparing the fusion bed. And if you have navigation, it allows you to do it with way less fluoroscopy and radiation exposure. And I think a lot better accuracy as well. The pre-pack thing, it depends what kind of graft you're putting in, but certainly I'll put in some of the facet that's morselized. But if you overdo it, it can affect your graft placement. And then, you obviously want to, when you're placing the graft, either have a assistant helper track. Usually it's not like this. There's, the nerves pretty close proximity, especially if there's a slip. And so you can either just kind of protect it with a pledget or, retract it with a freer or whatever, but just kind of account for it and make sure you're not getting any spontaneous EMG or any free running EMG firing while you're trying to place your trial, et cetera. Because you can definitely bag somebody's nerve if you just try to jam a cage in there and aren't thoughtful about it. And then post-pack, a lot of systems now will have some kind of like DBM inserter or something that's of sufficient low viscosity where you can insert it through like an insertion cannula. And then if somebody does have significant central decompression, you can do like an over-the-top decompression, just pull the tube back, look contralaterally and do a decompression. I actually prefer to do this up front and just finish the the fusion or the TLIF insertion for the very end, but certainly if you do it one way or the other, I don't know, it makes a big difference. So decompression is complete. And then you can do your screws. So the screws before or after, when I was in training, we did these mostly fluoro-based. And in that context, we would just do the TLIF and then we'd place our screws percutaneously with fluoroscopy. If you're doing it with navigation, obviously the fidelity of your navigation is going to be compromised by the interbody work because it's going to change the relationship of the vertebra because you're putting an interbody graft and hopefully getting some lordosis and disc height restoration, et cetera. So it's better to use your navigation up front. So put in the PSI pin, do the spin. I'll generally place the contralateral screws unless I'm doing a contralateral facet release. And then I will cannulate the ipsilateral screws. And there's this like navigation dilator tube where you can place the K wires through the cannulation track, and then you can just bend them out of the way so that there's room for your TLIF. So this is kind of what that looks like. You've got the contralateral screws, and you've just got K wires in ipsilaterally so that you can drop your tube down and not have it be obstructed by the tulip heads. And that's the picture of Ryan and I doing that. Oh, this is just, we're doing bilateral. So in this instance, obviously we couldn't put any of our screws in because we needed both sides to be accessible. Screws in over the K-wire. That's it. So that's a lot. MIST left. But unlike like the last 3 times I've given this talk, there's like some people in the audience that probably do this operation with some frequency, I'm hoping. So like, what do you guys think? Like, what have you learned? Like for me, a big thing was don't just like crank up on the expansion mechanism. Don't try to like maximize lordosis. Have some sense of what the bone will handle. And the graph probably matters. Like I've had pretty different results in terms of what I can get from an alignment standpoint and subsidence and stuff like that by using different graphs. And my indication has gotten pretty narrow. Like I essentially do MIST lift for the most part for one indication. It's a 4-5 listhesis that needs direct decompression or that has bad psoas anatomy. If it's 5-1, I'm going to do an A-lift unless there's contraindication like abdominal history or some other reason. If it's 4-5, I'm going to do a lateral unless they need direct decompression or if they've got psoas anatomy that's tenuous. So that's kind of like my TLIF indication. 4-5 needs direct decompression or has bad psoas anatomy. And above that, I'm usually doing lateral. So it's gotten pretty narrow. But like as the indication for me has gotten very narrow, we have this thing called FORCE here where they track like our preoperative and our postoperative like oswestries, preoperative and postoperative pain. And it's like after cervical arthroplasty, it's like my second best procedure in terms of delta. And I think it's maybe because it's like that very specific clean indication and because, I don't know, if you have the right patient and you take a couple things into account, it actually can work pretty well. Now I've only been in practice for 5 years, so maybe they will all like have adjacent segment disease because I didn't get enough lordosis in 5 years from now or something like that. We'll see. Anyways, anything you guys have learned in your early years or in training? Presumably you guys are doing this too, minimally invasive surgeons.
Yeah, I am. I think in talking to Peter and a bunch of other people that do a lot of MIS, exactly what you're describing, people are doing less and less of them. You know, I think the indication, there are certain guys out there that this is kind of their workhorse and can be done very, very well.
Right.
There's such a variability in terms of efficiency and what you're able to get, both from a direct, indirect decompression standpoint, fusion rates. But I think sort of the reliability of a lateral and ALIF, if people are kind of MIS inclined, to become more proceduralized, commonly used. But it's kind of my favorite thing to talk about because there's that variability in technique and steps and indications. And so, you know, I saw a bunch of different ways to do it in training and I'm still kind of optimizing my like preferred workflow.
And you did your fellowship at Rush?
I did.
Yeah. So you saw like Kern, like he's like super fat. Like, there's a lot of between like even Kern and Frank, like and then the neuro guys, like huge variability. They all do it differently.
Absolutely.
So
my sort of big realization / frustration coming out of training was that, you know, I saw MIST lifts at HSS. They do them really well there, but it was always a unilateral facetectomy. And I don't think I saw a single direct decompression apart from the IAP removal the entire year. And I go into training and, you know,
that's how you do a 45-minute TLIF or whatever people
Right,
say on their,
right.
They're like Instagram counts.
Yeah. And then I go to practice and I'm seeing these patients with pictures like that one CT scan you showed.
Yeah, it's like grass totally splattered.
Or I mean, like there's like bony.
Oh, yeah.
Bony recess stenosis, horrible central stenosis.
Yeah.
And I'm like, this is not a great candidate for unilateral fascectomy, no direct decompression, TLIF. And so I feel like if you want to do an MIS TLIF correctly, it probably has to be something similar to what Kern does, where you do bilateral fascectomies, compress on the screws,
Right.
plus or minus on the direct decompression. And I feel like that's 5% of MIS TLIFers do that.
So that's a great point. Like if you're doing a lateral and you get the graft in the right place, or you're doing an ALIF and you get the graft in the right place, unless there's like some crazy like spondylotic joint like this, like it's probably going to work. Where there is probably more user variability.
Yeah.
And that's maybe why TLIF's gotten that name, because you've got dudes that are not, and women that are not doing proper decompression, or they're not doing proper release, or they're not really thinking about the lordosis. They're putting in like a 7-degree cage and not compressing. And at like 4 or 5, you know, like that's going to cause major issues. But I think you can divorce like bad surgery from a bad procedure, and if it's performed appropriately, even though it has limitations.
Right. I will say I've used one of the companies, I think we're talking about the same company,
Yeah.
has like especially if you use a robot, they have a software package where you can pre-plan the cage the same way you pre-plan your screw trajectories.
I like the position of it.
Yeah, so you can
Oh, cool.
kind of drag a cage into the disc space. This is where I want it to be right up front, midline.
Yeah.
You can kind of choose the dimensions of the cage. And then when you're doing navigated disc prep, you will see the superimposed cage plan
Oh, cool.
where you're disc prepping. And you can be like, wow, I'm way off.
Yeah.
If I'm not going any more cross court than this, my disc prep's going to be over here. My cage is going to be off. So it's not going to be anywhere near where I want it. That's something that I think is neat, that if you're going to do an MIS TLIF and you want to optimize like placement and make sure your disc prep is in line with where you want that cage to be, it's like a nice adjunct.
Yeah.
And obviously, like I said, you avoid some of the X-ray burden and stuff like that.
100%.
One thing
Have you ever tried like navigated disc prep in the lateral space?
Yeah.
I have too. And I just haven't found it. It's useful for like when you're going across, you don't have to like take an x-ray when you're doing a contralateral release. Like it can save you some x-rays, but for whatever reason, like I just don't think it's as amenable to like the delta between doing a TLIF navigated in terms of like ease and things like that versus doing it a lateral navigated just seems like it's much more amenable to navigation. Or navigation helps more than it does for lateral work, in my opinion.
Yeah, I would agree with that.
Yeah.
I guess.
Yeah, I would too. I think you have just better visualization.
Yeah.
Or, the orthogonality kind of lends itself
Yeah.
to understanding where you are with fluoro. I think with a lateral, I'd probably still get a fluoro anyway,
So do I.
That's
why I'm like, is this
It's kind of nice to be able to look at it, but
Yeah.
really changing my steps or limited.
It's not, right, yeah, I agree. Because you're doing so much force, we need the fluoroscopy to like confirm
I think the dilator placement initially on the disc, maybe you save
That's the only time it helps.
a few X-rays there.
That's the only time it really helps.
You kind of get a straight shot, like you're down.
Yeah.
But then everything involving disc prep, I think it's kind of like
It's a fluoro-based procedure.
yeah.
That's been my experience.
Yeah.
So, let's do all this fancy disc prep and get your navigated. I know exactly where I want to get it. So like my navigated thing, I'm going to navigate my, like exactly where my curettes go. I'm going to be able to stick this big, fast
You see what I deal with?
of metal into this space that has zero room for bone graft. So like, I make
Yeah. No. Yeah.
flamboyant excuse here, but like, I think that's part of the issue too, in my opinion, is like, you're not conferring end plate to end plate stability, right? You're not getting a apophyseal ring like you do in a lateral.
Right.
And you're losing out on your graft window, right? So you're leaving the whole annulus in place typically because you don't want to take the annulus out. That's probably a solid 30% of the disc space, if not more. So really all you're doing is nucleectomy, right? Like you're taking the nucleus out and that's it. And then you're trying to stuff a pretty whatever sizable implant in there, and you really have very little space for fusion. That's probably my big concern on MIST looks is like a lot of them, when we go back and revise them, you go in there and they may look fused or spot welded on a CT, and you get in there and that thing is like wiggling around. It's because you are spot welding it,
Yeah.
Difference of the lateral is even if you don't get a fusion, that thing is not moving, right? It's tension between bones on the apophyseal ring. And I think that's why the fusion rates are so dang high, or the revision rates are lower in that setting, because get like mechanical stability from the implant itself, even if the fusion doesn't occur.
Yeah.
I think that's the part that for me, that's hard to
It's hard to counter.
Hard to give up.
Yeah, it's hard to argue against that point. I think that's just true. I mean, it's the only procedure I use BMP for still, unless it's like a smoker or something, but like I won't use BMP for laterals or ALIF anymore. I just don't think it's necessary with 3D printed porous circumference. I mean, those cages are so bioactive now with on growth. I just don't think you need it. And we've studied it and have shown that you don't really need it. But for MIS TLIF, I still use it just because for the reasons Greg mentioned.
I was going to ask you about your graft choice. Have you seen any like post-op neuritis or any of those like complications?
From BMP?
Yeah.
I've seen post-op neuritis a couple of times. I don't know. I've never not used BMP, so I don't know like if it's BMP related. And I've had a seroma or two.
Any cases of HO, like on your fast action?
No, that I've not seen. What I usually do is I'll put the little sponges in first. I'll like put, I'm a little paranoid about it. So I'll put like a cottonoids on the fecal sac and on the exiting nerve root. And then I'll put the BMP in like first and I'll make it into like a little like joint. So like I try like not to touch anything. So I get it in the disc space. And then I shoot in a little, yeah, it's exactly what it's like that. And I shoot in a little DBM, like putty, to like kind of like create like a little barrier. Then I put in the graft. And sometimes I'll put like a little sponge in the graft. And then I backfill with like DBM fibers. And then I kind of like seal, like spackle it at the back of the disc space. So I feel like there's like a barrier.
Yeah.
It's like the least evidence-based thing you could possibly do, but it like makes me feel better.
I think it matters. Yeah.
Yeah, I'm like creating like a couple mechanical barriers because there's a lot of obviously experience with that problem. So what do you do if you, I mean, that's just like a brutal, like go back in there, try to like drill off heterotopic. Yeah, you can really bag somebody that way.
I have a couple of those.
Do you? Yeah.
Those things change too, right? Used to use big doses.
Right. I'm using extra small. Yeah.
Are you leaving drains in for, for seroma stuff?
For seromas, I mean, if you've done enough disc prep, like it should bleed a little bit.
Yeah.
You know how I am with drains. It's like
We never did in residence.
drains are like I'm like super idiosyncratic and like maybe irrational, but it like makes me feel better to have a drain in place. I have like a lever to pull for like the first couple of days. So the fellas are constantly like, what does this guy steal with the drain?
I think the thought occurs to me, and we did a lot of work looking at the segmental lordosis for laterals. And I agree with you. I think the delta is not as much as people think.
Yeah.
But it's, like there's a very large spectrum of what you can achieve radiographically with a TLIF. And I think lateral probably raises the floor, for your standard MIS TLIF.
That's a great way to put it.
The ceiling might be very close and comparable for MIS TLIF and lateral, at least in my hands. But in the hands of like an experienced MIS TLIF, I would say, rather than my hands. But I think the floor is much lower. In terms of graft selection, I've kind of done this yo-yo where when I first started, I was using pretty much religiously the expandable, TLX, I'll just say it, that was kind of like what I used, and they all subside.
Right. That's the one I showed.
And just they all subside. And so I moved towards using a static cage, a rotating banana static cage to put up the front, but it's technically very demanding to do that through an MIS TLIF corridor. You really have to have this. So I typically would use a pedicle screw based retractor. And you have to have the pedicle screws in the right trajectory for that cage to work. Because if they're over medialized, like if you're at somebody at 5'1" and they've got, more sacralized kind of anatomy, and so your screws are, it can actually be pretty tough to get the cage, to the midline or ipsilateral if you want it there. It always ends up being like way
control, right? And you're looking at a gnarly angle.
You're looking at it crazy, so you have to kind of just be cognizant of that and just force yourself, either with nav or with fluoro to take a less medialized trajectory. The one thing that has occurred to me, and I a few years and not quite as much as you, but there's just much more variability with my outcomes clinically and radiographically with MIS TLIF versus lateral. I mean, just not much variability. They kind of are what they are. Still miserable, but but they are.
That's perfectly said. I think it's the floor is potentially lower. The ceiling is probably pretty similar if done correctly. But that's why I think my indications have shrunk to like that basically one case, like 4 or 5 sponded needs direct decompression, can't be done via lateral. because of psoas anatomy.
Dr. A, you got something you want to say?
Yeah, again, welcome to all the fellows. And I think my comment would be more in spinal deformity and basically on the history, as what I'm pretty sure because the history has happened. The rest of the stuff, especially the technology that you all are using these days, I'm not uh, that much experience in navigation and things that you do, but I think the reason we first sort of were attracted to lateral was the fact that I thought that for the deformity we really need to look at the entire disc, end plates, and so on. And with lateral, we could see that. And I had a partner, Bruce Van Dam, who was came from Walter Reed, and he and I always had this issue of TLIF versus at the time was anterior as well as lateral. And he was a great surgeon. He was able to get, for the indications that Hani mentioned, simple cases that you really didn't need that much correction. Got good correction, and he claimed that he get a better, not better, but as good as lordosis as laterals. We always had this discussion, but I think the fact that you have ability to even correct it segmentally more, like doing an ACR or other procedures, it's hard to do it. And I never was able myself to look at the entire disc and make sure that I get a good fusion. So I think hopefully, as you mentioned, there's not much data. I would hope that with the advancement of technique, you probably should be able to do both. But I think the principle is to get a good fusion and to do good fusion, not needing extra help. And you see the plate, you need to prepare it right. That is full of good, good graft and good vascular and connection. So hopefully you will be determined soon by you guys when you do more cases and do more research. So looking forward to see you all tomorrow at lunch.
Thank you.
Thanks, Dr. Ed. I'll add one other little tidbit that I think it's good to sort of think about. And, I started back when laterals first came out and trained before laterals really started to come about. I think about it in two different ways. I think, as Beirut just talked about, there was this debate about TLIF versus lateral. But you have to take yourself beyond that a little bit. They did all open TLIFs. When you go to MIS, there's an attraction to do that because there's less morbidity for the patient. But we have to go back and start rethinking the biomechanics, the fusion rates, and the lordosis segmentally when you do that. So it's not that MIS TLIF is bad or good. It's can it do the same things? Will it suffer different circumstances in the end because of the biomechanics? And so you have to break it down into little pieces. Back to what you were talking about with the graft or the cage. The cages are smaller. They're in a different place in the bone. They're biomechanically just not quite as proficient.
No question.
And if you have screws that we use now, which are polyaxial, they will only withstand certain loads. So even if you can achieve certain things in the operating room, that doesn't mean that patient's going to sustain what you achieved and you're going to maintain lordosis. It's already a challenge with bigger cages. You hyperload those screws and you're going to get subsidence in a certain percentage of patients. And then you look at Irvin stuff, those were open, I think, right? So they're doing relatively big wax. You're not talking about MIS anymore.
Right.
you're losing all the benefits that we know we can achieve with MIS. So while there's a place for MIS TLIF, I think you have to sort of break it out into, is MIS the right thing to do? Is that the best thing to do? Can I achieve what I want and maintain it with MIS, and then figure out what tool you're going to use? There are some cases where MIS TLIF shot because you can't get there laterally. It's a young male. They don't want to take a hit and have retrograde ejaculation. So keep it in your armamentarium, do a good job. And I think one of the big things that we will have to determine is, at this point, do we go to bilateral fast techniques? Do we do things that really make it feasible to attain the lordosis and then hopefully attain it with whatever we need? Is that an expandable cage that fills the space better and supports the screws in more favorable ways? Is it 2 cages? I don't know the answer to that, but I think those are the questions that we can answer, knowing that it's still going to be an important part of our